Hello, everybody, and welcome to the 2025 IFFS Endometrial webinar series. This is the second of two, and I'm very honored to be chairing this session jointly with Dr. Linda Judice from the UCSF and past president of IFFS. My name is Marcos Horton, and I'm president-elect of IFFS. Today, we have two spectacular speakers. I'm very pleased to present Dr. Elena Labarta. Elena is an assistant attending physician and surgeon in EV Valencia, Spain. She studied in the University of Zaragoza and completed her training in the University of Madrid at Hospital La Paz. She is Dr. cum laude in medicine in the University of Valencia, where she also coordinates a master's degree in human-assisted reproduction at that university. As you may know, she has published extensively on the matter of progesterone levels during HRT preparation for frozen embryo transfers. So, Elena, we look forward to your presentation. Thank you and welcome.
Thank you, Marcos, for your kind introduction. Let me share the screen. Fantastic. Can you see them?
Perfect.
Perfect. Thank you. So for me, it is a pleasure to be with all of you, dear colleagues, talking about this fascinating topic, which is the comparison of natural cycle versus HRT cycle for frozen embryo transfer. And I'm not going to focus only on progesterone because obviously you could expect that I'm going to talk about progesterone. But I think that it is important to do a general overview of all the differences that we can observe in these two different types of endometrial preparation protocols in order to choose the best one for doing the embryo transfer in this scenario. And why it's so important? Because we are assisting to an increase in the percentage of frozen embryo transfers nowadays. In fact, the last ESRE registry estimated that 36% of the transfers nowadays are frozen embryo transfer cycles. So it is essential to decide which is the best endometrial preparation protocol for doing this transfer. We can choose between ovulation induction, mainly in anovulatory patients, or doing a natural cycle, either pure or modified, or an artificial or HRT cycle. In most of the cases, we will be choosing between the natural cycle and the artificial cycle. And the question is, which is better? Because for many years we've been using the artificial cycle. Perhaps we have been overusing the artificial cycle because it is like more convenient in terms of programming the embryo transfer. But nowadays there is an ongoing debate about the needing to move towards a more physiological approach. So in order to answer this question, I have divided the lecture in three parts just to cover these topics. One is efficacy in terms of results. Second is the cost. And the third one, and very important, is the safety. So regarding efficacy, obviously, it is something very, very important because all of us want to have the best pregnancy rates in our patients. And for many years, there have been many studies trying to compare the implantation and clinical and ongoing pregnancy rates between natural and artificial cycles. The problem is that most of the studies have been observational or retrospective studies. In fact, if we look at the meta-analysis published so far, comparing natural versus artificial cycles, you see that the limitations of these meta-analyses are that they are based on retrospective studies and studies with a high heterogeneity. So the conclusions have to be interpreted with caution. The first two meta-analyses in this table did not find a superiority of one protocol over another. And the last one, published in 2021 in Heart, suggested a superiority of the natural cycle versus artificial cycle in terms of live birth rate. But obviously, the ideal mode to answer this question is to look to the randomized control trial. And unfortunately, there are not so many studies like that comparing natural versus artificial cycles. There are two of them published so far. The first one was the Antarctica trial, which compare the modified natural cycle versus the artificial cycle. It included 959 patients, so the study was quite big. And when they compared the results, they couldn't see any difference in terms of clinical pregnancy, ongoing pregnancy, and live birth rates. The limitations of this study, acknowledged by the authors, is that the required sample size was not achieved and they couldn't reach the statistical power, and that the live birth rate that they observed in this study was significantly lower than they expected from the beginning. So results have to be interpreted with caution. But a second randomized control trial has been recently published in Lancet in 2024. In this case, they compare three groups because they differentiated between the pure natural cycle without any additional medication and the modified natural cycle, in which they use ACG for triggering ovulation, and the artificial cycle. The main outcome was live birth rate, and they included 1428 patients. So sample size was quite big, although having three groups, obviously the statistical power decreases in comparison of having only two groups. But in any case, they couldn't see differences in the live birth rate and other pregnancy parameters in the three groups compared. So if we are based only in randomized control trials, we can say that there are no significant differences in the natural versus artificial cycles, but as you can see, we have only two randomized control trials published so far. In any case, I would like to share with you our own experience in our clinic in EV Valencia, because in the last years we have switched to the natural cycle. At least we have increased the percentage of patients using this type of endometrial preparation because, well, among other factors, because we were aware of the problem with the luteal phase defect observed in many artificial cycles, as I have published previously. So we have switched from 46% of cycles in 2023 to 75% during last year. So nowadays we are doing much more natural cycles. And when we compare the results of artificial versus natural cycles in PGTA cycles, just to rule out the embryonic factor, we saw that the ongoing pregnancy rate was significantly higher in natural cycles. I'm talking about modified natural cycles because we are triggering with ACG the ovulation. And you can see that the odds ratio was 2.38, which was clearly significant after adjusting for confounding factors such as age, body mass index, and embryo quality. And it is very interesting to see the miscarriage rate because we were in a context of PGTA in which it should be low, and it is nice to see how in the natural cycle we have a significantly lower miscarriage rate than in the artificial cycle. Obviously, this is an observational study. It was just to share our experience with all of you, but I think that it is important to let you know this information. Well, the second part, and very quick, is the cost, because there is only one study comparing this, and it is the Antarctica trial that I mentioned before. In this study, they very nicely compare the cost derived from both types of treatments, considering everything, the scans, the blood analysis, the travel expenses, the parking, and everything, and they couldn't see any difference in the cost of in the additional cost of the treatment per live birth obtained. So we can conclude that it seems that there are no differences. Obviously, this will depend on the country and on the number of controls that you are going to do in both type of protocols. And finally, and very importantly, let's talk about safety in terms of the obstetrical and perinatal risk. And this is a hot topic nowadays. In fact, the landmark study was published in 2019 in the journal Hypertension, in which they compare the risk of preeclampsia and severe preeclampsia depending on the type of endometrial preparation protocol given to the patient and the presence or the absence of a corpus luteum. And as you can see, when there was an absence of corpus luteum, which is the artificial cycle, the risk of preeclampsia was significantly higher when compared with cycles in which there was one or more corpora lutea. And the authors concluded that perhaps this absence of corpus luteum can perturb the maternal circulation. Why? Because the corpus luteum is not only progesterone, the corpus luteum produces also relaxin, oxytocin, renin, aldosterone, and other vasoactive compounds, which can help into the maternal vascular adaptation and can favor placentation and prevent from this preeclampsia. There are two recent systematic reviews and meta-analyses comparing the obstetrical risk between natural and artificial cycles. The first one was published by Busnelli in 2022, and they observed that in artificial cycles there was a high risk of hypertensive disorders of pregnancy, preeclampsia, postpartum hemorrhage, and cesarean section. They concluded that recommendations should not be done at that moment because of the weaknesses of the included studies. So they said, we have found this, but we should wait for proper studies to understand if this is a selection bias result, because perhaps those patients doing a natural cycle were better prognosis patients from the beginning. In any case, 1 year later, THAT published another systematic review and meta-analysis and concluded that natural cycle decreases the obstetrical and neonatal risk. And as you can see in the table, the artificial cycle increases the preterm birth rate, very preterm birth, hypertension, preeclampsia, or hemorrhage. And once again, the limitations logically is that the included studies were observational. So, in response to this second meta-analysis, Busnelli wrote a letter to the editor and suggested that perhaps the reduction of the artificial cycle could have a negative consequences because it can reduce the opportunity to program the transfer of the embryos. It can induce a high volume of work in some days of the week, or that the overusage of incubators and their opening could finally impair the results in the laboratory. And he said that perhaps suggesting the total abandon of a regimen on the basis of associations coming from retrospective data is in disagreement with the rules of epidemiological research. So he said, let's wait and see what happens with future studies, and proposed something that could be interesting and reasonable, which is to stratify the obstetric risk in the preconception phase in patients when considering the option of doing an artificial cycle. So if a patient has some 2 or more exposure factors, such as a high body mass index, hypertension, advanced maternal age, perhaps we should avoid this type of endometrial preparation protocol. And this would be the ideal situation, I would say, to stratify the risk and decide when to do it. In any case, the answer will be given by this, I think, by these two studies. These are 2 randomized control trials who have been designed which have been designed to compare the risk of preeclampsia in natural versus artificial cycles. The first one, I think, is still recruiting, but the second one, called Preeclamp, was conducted in our centers, and the results have been submitted, not published yet. And I have to say that we couldn't see differences in the risk of preeclampsia because the numbers were very low. So obviously there is no statistical power enough to conclude anything. But interestingly, we observed a higher liver rate with the use of the natural cycle. So this is something to take into account. Coming back to the role of the corpus luteum, I think that it is important to reinforce the idea of the vasoactive compounds that are produced by the corpus luteum, which help into the maternal cardiovascular adaptation, but also, and very importantly, the production of endogenous progesterone, because if a patient ovulates adequately, the serum progesterone levels are going to range between 10 and 13 nanograms per ml, which are quite good in the mid-luteal phase. And this presence of corpus luteum help us to decrease the needing of exogenous progesterone. So there is ongoing debate about the needing or not of adding exogenous progesterone to natural cycles, but according to the literature, it seems that the addition of exogenous progesterone is beneficial in natural cycles, but the advantage of the natural cycle is that you don't need to give so much progesterone as in the artificial cycle, in which very high doses are needed to compensate the lack of corpus luteum in this scenario. So, having said this, obviously, it is logical to think that it is convenient to move to a more physiological approach, to try to do more natural cycles if possible. But still, some doctors are reluctant to use the natural cycle because the difficulty in programming, sometimes they need more controls, and sometimes there is a risk of premature ovulation. And I would like to tell you that we have good news, because there are some novel natural cycle approaches just to facilitate our lives to the clinicians and to promote the use of natural cycles. The main concepts of these new approaches are that we should forget about reaching a big follicle size, because we need a good follicle but not a mature oocyte, and focus on the endometrial growth. Once the endometrial thickness is 7 millimeters or more, we can go ahead with the embryo transfer. So I would like to show you two options to program the natural cycle. One is with the use of ACG for triggering ovulation. This option consists on giving the ACG once the endometrium has reached a minimum of 7 millimeters, and we have a follicle greater than 13 millimeters. So we don't need to wait for the follicle to be in 16, 19, or 20 millimeters, because once we have a good endometrium, we can trigger the ovulation with ACG, start with progesterone. Obviously, we are talking about giving a luteal phase support. We are not talking about a pure natural cycle. And this allows us to schedule the embryo transfer 5 days after starting the progesterone. And this protocol has proven to be effective, and the results have been published by Dr. Alonso from EV Madrid, who demonstrated that results were absolutely comparable regardless the size of the follicle. So this opens the window of programming the embryo transfer once we have the endometrium ready. And the second option is the so-called natural proliferative phase frozen embryo transfer, in which no trigger with ACG is needed, and it consists on waiting naturally for the endometrium to be higher or thicker than 7 millimeters, and we have a follicle of 14 millimeters. At that moment, we could start directly with progesterone at a dose of 400 milligrams every 12 hours, such as in the artificial cycle, and not triggering ovulation. So 5 days after, we can do the frozen embryo transfer cycle without hampering the results, as it has been demonstrated and published already by 2 groups, as you can see in human reproduction. So these 2 options give us another way of programming the natural cycle, and obviously facilitate the programming of the embryo transfers. So perhaps with these approaches, we are more prone to move to the natural approach. So just to conclude, I would like to summarize these 3 points that I have mentioned during the lecture. In terms of efficacy, as I said, the 2 randomized control trials showed no differences between the natural and the artificial cycle. In the meta-analysis on the observational studies were included, and that's why the results are not conclusive. The costs are similar according to the literature, and regarding safety, higher obstetrical and neonatal risk have been observed in artificial cycles, and these differences have been attributed to the presence of the corpus luteum, which is essential for the maternal cardiovascular adaptation. And also, apart from that, the corpus luteum helps produce an endogenous progesterone, which can avoid extra treatment with for luteal phase support. And the future is to switch to natural cycle when possible, stratify the patients to calculate associated risk if considering the use of HRT cycles, because we have to assume that we will continue using HRT cycles for sure in many cases, and use novel approaches to facilitate the natural cycle scheduling in the natural cycle approach. So with this, I finish my talk. I will be happy to answer your questions after the session. Thank you so much.
Thank you very much, Elena. I'd like to turn it to Linda for the second presentation, please.
So I also want to thank Elena for a wonderful talk, and I'm delighted to present Dr. Kate Devine, who is a board-certified reproductive endocrinologist. She is currently medical director and chief research officer of the Shady Grove Fertility Network called US Fertility. And she is also clinical professor at George Washington University and associate director of the REI Fellowship at the NIH. Dr. Devine did her undergraduate training at Columbia University, got her MD degree at Albert Einstein College of Medicine, and did her REI Fellowship at the NIH. She has worked extensively in the field of global women's health, working with the Organization for Women and Development in Niger, as well as working with the Child Family Health International in Quito, Ecuador. So today she is going to talk on, can we optimize endometrial receptivity and who might benefit? Kate, welcome.
Thank you so much, Linda, for that kind introduction and for this opportunity to speak with you all today. I just wanted to make sure that you can hear and see me okay, and then I'll go ahead and share my slides.
We can hear you and see you.
Terrific. Okay, well, thank you so much. I'm going to be kind of hopefully rounding out this panel that has been over these last 2 weeks and really kind of talk about, in terms of endometrial receptivity, who might benefit from additional interventions and diagnostics, and really kind of where are we in terms of the state of our understanding of recurrent implantation failure. So I don't have any relevant disclosures. And so just to give a little bit of background here. So here we're talking about recurrent implantation failure. And when we talk about recurrent implantation failure, we have a big problem to start with insofar as we don't have a universally agreed upon definition. And so there are 76 definitions overall. And the most commonly accepted would be to have 3 or more embryo transfers or 4 blastocysts having been transferred. And so you can see some references here as to where those definitions come from. In terms of our professional societies on whom we rely to guide us. Only ESHRE, out of ESHRE, ASRM, and SART, has provided us with a definition. And the definition that ESHRE provided, you can see here. It's the transfer of sufficient presumably viable embryos has failed to result in a positive pregnancy test, or an estimated cumulative chance of implantation to date of at least 60%. So a little bit vague in terms of this first bullet as to what's sufficient. And I think many of us would argue a little bit low when we say 60%. So many of our centers would estimate for our patients 60% probability of a baby from one chromosomally normal embryo transfer. And I certainly would argue that I would not consider that to be recurrent implantation failure. The ASRM Practice Committee is considering this question, and we are expecting a practice guideline from ASRM in spring, summer of 2025. There's no universally agreed upon decision from SART. So we'll focus for a few slides here on the ESHRE definition and recommendations. And so this is a figure from their guideline on recurrent implantation failure. So more than one embryo has failed. Consider the likelihood of implantation in the next cycle and counsel patients of their pregnancy, prognosis for a future cycle. If we think that there was less than a 60% probability of sustained implantation pregnancy after whichever transfer just occurred, then we should just carry on, keep calm, transfer another embryo, proceed with treatment, and it goes back into this loop if not successful. Once we get to the point where we've met ESHRE's definition and greater than 60% would have been expected to have a successful pregnancy following that transfer, then we call them recurrent implantation failure and follow up with the specific interventions. Again, not necessarily agreeing with this recommendation, but that is the recommendation from ESHRE. And so good news is they're pretty conservative in terms of what they recommend for those specific investigations. So the only things they kind of recommend are lifestyle recommendations. So obviously if a patient is obese, sedentary, smoking, things like that, we want to help them get healthier because that will likely improve their probability of success, or that is the best, most evidence-based thing we can do for them. And we want to make sure that the protocols have been successful in developing their endometrium. And you just heard a great talk from Dr. Labart about which protocol you might choose. That said, obviously, we don't want to be replacing an embryo into a suboptimal uterine or endocrine environment. These are things that they feel are reasonable to consider. So karyotypes for both partners to determine whether there might be some structural rearrangement that could be negatively impacting probability of success. Obviously, anatomic evaluation of uterus. Hopefully, we've done this already. Whether hysteroscopy is indicated as a substitute for less invasive evaluations is a subject for another day. Consider evaluating for chronic endometritis, which we'll briefly touch upon later, but as itself kind of a can of worms. Assess thyroid function. This is also becoming more controversial over time as ASRM's practice guideline has recently recommended against the routine evaluation of thyroid function if the only diagnosis that we're working with is infertility, and evaluation of serum progesterone concentrations. ESHRE does not recommend endometrial receptivity tests, microbiome testing, natural killer cell testing, either in the peripheral blood or the uterus, HLA compatibility testing, thrombophilia, mtDNA content, or DNA sperm fragmentation or FISH for the male. So interestingly, another important question is, do we even need a definition of recurrent implantation failure? Is there even such a condition or diagnosis of recurrent implantation failure? And so to elaborate upon that, it's a little bit complicated. So There's no consensus, as we already discussed. And, you know, certainly we have some patients who we just don't expect to become pregnant because of really kind of robust negative prognostic factors such as female age. So if we can't diagnose, or if we can't define, can we really research it? And if we can't know its prevalence or who has it, how can we assess which treatments are going to be efficacious? And so for patients who are requesting testing and interventions and lack evidence, we wind up with docs that are prescribing unvalidated diagnostics and treatments. And this is just not good for patients. So this is something that as a field, we really need to achieve consensus upon so that we can really achieve the best outcomes with minimal unnecessary interventions for our patients. And so in terms of where we are in the trajectory of assisted reproductive technologies, we have a lot to be proud of, right? So if we look back to early days of IVF, obviously our success rates are very low, whereas, you know, currently we're doing a lot better. And so, you know, why is that? So in 1980, the implantation rate was very low, around 10%. We did day 3 transfer. Then we moved to soft catheters and ultrasound guided transfers. We normalized endometrial cavity, focused on endometrial thickness and pattern for optimal implantation, which, you know, again, still controversial, but getting closer to consensus and acknowledging the importance. We've done day 5 transfers. Some folks would advocate for freezing all. Some folks would advocate for PGT, and controversial, but maybe helpful. That said, we're not all the way there, right? 30% of embryos that we would deem high quality do not implant. And so why might an embryo not implant? So, you know, I would argue that number one, and in the overwhelming majority of cases, no matter what diagnostics we've done, it's probably the embryo once we've ruled out endocrine and uterine anatomic issues. But endometrial factors may still apply for some patients, and that is a little bit nebulous at this juncture. And so there's endometriosis argued. Obviously, Dr. Giudice is an expert in this area. That could potentially impact implantation. There are immunologic factors that are unfortunately quite poorly understood. And we need to figure out which patients should we be directing towards these types of evaluations. And so when we think about live birth rates currently from PGTA normal embryos, there's a huge range, and thankfully they've improved, as we just discussed. But not all PGTA normal embryos implant, even when we think we've optimized everything. So what do we do if this happens multiple times? Do we tell this patient that she has recurrent implantation failure? And I would try to define recurrent implantation failure as a true biologic resistance to sustained implantation in the setting of an optimized hormonal and uterine anatomic environment. And so just to kind of think about recurrent implantation failure in light of large data sets that we have access to. So based on the SART 2020 data, in young, good prognosis patients with a chromosomally normal embryo on PGTA testing, they found 62.5% implanted in the first transfer. And for those that had an unsuccessful first transfer and went on to a second transfer, 55.5% of those implanted. So, and then in 2021, the data looked quite similar, and the absolute difference in terms of probability of implantation was not really very significant. And so this kind of starts to beg the question of, because this isn't totally unadjusted analysis, not able to weed out those patients who perhaps did not have an anatomically and hormonally optimized cavity in that first transfer, that perhaps this isn't really a significant difference. And it gets us thinking about, okay, is there such a thing as a true biologic resistance to sustained implantation? And again, these are the same data just shown in a graphical format. And so a number of investigators have started to focus on this and trying to analyze large data sets to determine whether in fact a true biologic resistance to sustained implantation is real, exists. And it started with this paper by Dr. Atta, which was modeling, where they modeled out kind of how many embryos would be needed to really kind of make this diagnosis. And so they looked in this paper at both euploid embryos and just all embryo transfers. And you can see here kind of what they modeled based on known published implantation rates would be the number of embryos needed to be transferred to get to success. And you see here that, you know, if we, and this is sensitivity analysis where we're assuming 45, 55, or 65% probability of implantation from a euploid embryo. And as we see, you need to get to a lot of embryos transferred before we're in this rare category of fewer than 10% of patients still left without sustained implantation. And then again, this just shows the same thing in terms of embryos transferred, not tested based on age and understood rates of euploidy for age. So we can see here, not everyone's doing PGTA. That's totally appropriate in my opinion. But when we're talking about a patient who is 42 years old, if we're assuming a 45% implantation rate for normal blasts and how many blasts they need to have one normal, we're talking about getting to transferring 24 embryos before we get up to an 85% chance of implantation. So again, some patients are poor prognosis anyway and are unlikely to be making chromosomally normal embryos. And I would not call them recurrent implantation failure. Because that can be discouraging, cause treatment dropout, and discourage them from considering maybe what's the most appropriate treatment for them, which would be a donor egg. If they in fact have true biologic resistance to implantation, we wouldn't expect a donor egg to be helpful to them. Whereas, you know, obviously it would be if the problem is the egg quality. And so using real data, Dr. Pirtea, and I have to thank Dr. Pirtea for his you know, we've worked on this issue together in the past, and some of these slides are attributable to him and his input as well. And so he looked at a group of patients from RMA, New Jersey that underwent 3 successive euploid frozen single embryo transfers. And so it was a retrospective cohort study from 2012 to 2018 at RMA, New Jersey, as I said. It was qPCR, NGS, PGT, and they transferred single frozen euploid embryos. They excluded egg donors, gestational carriers, PGTM, thin endometria, defined as less than 7 millimeters, included a total of 4,429 patients, and you can see there their age and BMI criteria, and they did require morphologically normal uterus. Descriptive statistics, linear regression models, with adjustment for age, and a survival analysis was done in terms of cumulative probability of sustained implantation. And so what they found was that 30% did not implant from the first single euploid transfer, and 571 of those patients dropped out. So they ended up having 307 that underwent a second transfer. Of those, they had a 60% probability of sustained implantation. And then in the third transfer, they had a 60% probability of sustained implantation. In terms of the statistics, it was a small but statistically significant difference between the first and second transfer and the first and third transfer. However, there was no difference between the second and third transfer, and in terms of survival analysis, 95% of patients would be expected to have a sustained implantation following 3 transfers. In terms of conclusions, they didn't think, based on these data, and I agree, that they had an increased incidence of failing after the second transfer. And again, recurrent implantation failure, if it's real, is less than 5%. And so is it the embryo or is it the uterus when an implantation is unsuccessful? While we still don't really know, we know that recurrent implantation failure is quite rare going out beyond 3 euploids. In terms of this analysis, it was retrospective. There were multiple retrieval cycles that were included, and some patients dropped out, so we're not able to assess 100% of the data. And there may be some bias induced by which patients ultimately decided to drop out, but it was a large sample. It was all single euploid blastocysts in an attempt to normalize for embryo quality. And they were all sequential single embryo, frozen embryo transfers over a substantial period of time. But it was not powered to look beyond 3 transfers. And so what do we know about that? So more recently, last year, Gill et al., and this is actually from Elena's group as well, looked beyond that at transfers number 4 and 5. And so they looked at 124,000 patients. That said, it was a much smaller number, only 105 that went on to do a 4th or 5th transfer. The inclusion criteria and exclusion criteria were very similar. They were a little bit more liberal with what they considered to be an adequate endometrial thickness for inclusion. And they did also have the morphologically normal uterus. In terms of their outcomes, they did not find a statistically significant difference. If you look at table 3 here between the 4th and the 5th transfer, they actually were not powered. As you see here, there were only here a total of 105 patients undergoing, or 105 4th transfers and only 45 5th transfers. So they were not powered to evaluate for the difference between all of those 123,000 that underwent a 1st transfer and the 4th or 5th transfers. That said, just qualitatively, the probability of clinical pregnancy and live birth are still quite good, 40%, 53%, respectively, with even a little bit better in that small group of 45 transfers that underwent a 5th transfer. And ultimately, in terms of their survival analysis, about 98% of patients would be expected to achieve sustained implantation after the 5th transfer. And so, this is something actually you can see here. There's Elena, and there is Juan, who you guys saw last week. There's Paul. So we met in 2022 to try to establish a consensus and published a white paper on it that basically summarizes a lot of these data, just essentially suggesting that if we expected that sustained implantation failure is real, then the population should be enriched with patients with a true biologic resistance of recurrent implantation failure of implantation, I should say, with those successive transfers, right? The ones who are remaining non-pregnant should be expected to have lower rate of success, significantly so, because they are worse prognosis patients by virtue of their endometrium being resistant. And these data just do not show that. This is what it would look like in terms of the probability of success if, in fact, the remaining population was enriched with patients that had true recurrent implantation failure. And you see here, with a 4th transfer, things are really going down markedly and much more than we actually see. And here you see with reality superimposed on there, which is obviously quite discordant with what the data would suggest. And so in terms of the number of untested blastocysts that you would need based on age, this kind of harkens back to the first study we looked at by Beres-Atta. We're talking about 27 embryos in a 43-year-old. So we shouldn't be going around telling our 43-year-old patients that are transferring untested embryos that have gone through 3 transfers that they have recurrent implantation failure. So just in terms of briefly touching upon things that we might want to, that many patients do when their patients are desperate. And so you can see them all listed here. It's important to note that none of these have been proven to be efficacious. My excellent fellow, now colleague, Elizabeth Klein, and I published a paper in 2022 reviewing all the evidence on contemporary assays to assess endometrial receptivity. And we looked at a large number of papers that evaluated endometrial receptivity assay, and overwhelmingly the studies did not show any benefit. Similarly, evaluating for chronic endometritis, which is in and of itself an extremely controversial diagnosis in terms of how do we even make this diagnosis, neither identifying it or treating it clearly helps patients become pregnant from assisted reproductive technologies. And then in terms of other modalities that we reviewed, similarly, and the data are even more sparse for these tests, none have shown a true benefit. And so in terms of our conclusions, more studies are needed, but at present, when a patient has an unsuccessful good prognosis embryo transfer, we really want to keep calm and transfer another embryo, as we said at the beginning. And there are few interventions, unfortunately, other than making sure the patient is hormonally and anatomically optimized, that can help them achieve better success from transfer. And we just hope that they have good quality embryos. Unfortunately, we also don't have a lot of levers to pull there, but at least we can help them understand what their probability of achieving good quality embryos is. So in terms of concerns around these technologies, so I think I saw my mentor, Dr. DeCherney, on the call. This is an opinion piece in JARG, and you can see here that while there's limited evidence for IVF add-ons, there's a strong demand, and the onus is on the physician to counsel their patients appropriately, not to prescribe these unvalidated diagnostics. You can see here there are more of our esteemed colleagues who have come to the same conclusion, as well as the popular press. And this is actually an article in the New York Times about a study that my former fellow, now colleague, Nicole Doyle, and I published in JAMA about ARA, and that was an RCT. So I would just beseech you to kind of have a very high threshold to use these tests. I mean, I guess there is now a controversy over whether Hippocrates ever really said primum non nocere, but I think it is a good dictum for us still. And we should really kind of wait for the data and help to do high quality studies to get better data. So it's uncommon, certainly less than 5% of infertile couples, if it exists at all. We're talking about recurrent implantation failure. Reassurance and conventional therapies are warranted currently. And if we are going to call anybody recurrent implantation failure, they should have failed at least 3 euploid embryos, in my opinion. And when we're talking about untested, this may be many more depending upon female age. And again, endometrial receptivity assays, unfortunately, not ready for prime time. So in terms of future research, we are about to publish a paper going out to 6 successive transfers from our center, which has very similar findings to Gill et al. So stay tuned for that. And again, prospective studies are needed to evaluate these diagnostics. So I want to thank, as I already said, Paul, Liz Klein, Don DeZiegler, and I'd be happy to take any questions with Elena. I think we've got 7 minutes.
So thank you so much. This was wonderful, very thorough analyses. So there are some questions in the chat and also in the Q&A panel. So I'm going to start with Elena, and it has to do with what's the best estrogen level for transferring an embryo in an artificial cycle, and do these need to be monitored? And a related question has to do with endometrial thickness. If it's not 7 millimeters, should one add estrogen or just go for it?
This is a very interesting question because, well, according to the new novel approaches that have been published, they say that the endometrium should be higher than 7, but I think that is something based on their personal decision, okay? Because we in artificial cycles have observed that once we have reached 6.5, the results are absolutely comparable. And regarding the estradiol levels, I have checked this very carefully, and they are not impacting on the pregnancy outcome. So we should not insist on reaching 100 picograms per ml before deciding to introduce progesterone. Once your endometrium is ready, you can go ahead because you need the estrogens to achieve a good endometrium. And if you or the patient is able to achieve an adequate endometrium with a lower endometrial level, estradiol level, you can go ahead.
Thank you. So there's another question, and this is for Dr. Devine. For the studies that are from centers that did not suggest a high incidence of true RIF, the question is, what did clinicians do, if anything, after the successive failed embryo transfers? Could these have theoretically improved the embryo? Sorry, it's just jumped here. Could these have improved the success rates for subsequent embryo transfers?
So the Protea studies were exclusively from RMA, New Jersey, and the IVI was a multi-center study from multiple centers in Europe, and I can certainly share the reference in the chat after that. They did some sensitivity analyses to adjust for any diagnostics that were done in the intervening time. The authors from both studies, however, did not find that they made a difference, nor did they suggest that any of those interventions be performed routinely. One major difference between the studies was that in the IVI study, they did allow multiple transfers to be included. So they were all euploid or PGTA normal, but several of the patients undergoing a 4th and 5th transfer transferred multiple embryos. So, that's controversial, of course, when we're talking about euploid embryos, but we all know that our patients are quite desperate in that situation. And even so, they still got to like a 40 to 55% chance of sustained implantation. So, I would say of all of the interventions, that's the one that may improve your probability of achieving implantation, albeit at a higher risk for multiple pregnancies. So proceeding with caution.
So thank you. And a somewhat related question is, could you comment on the techniques used for embryo transfers, and could operator embryo transfer account for perhaps that tail end of the RIF that we're seeing?
Sure. And I think where we start to see small decreases, like including in Protea between the 1st and 2nd transfer, I would imagine that the most likely explanation for that is probably something like that. If the 1st transfer doesn't go well and the 2nd one, reflects a group of patients that have difficult embryo transfer, or perhaps while they, this is not an RCT. So even though attempting to exclude uterine factor, it may not be able to be applied with 100% accuracy. So I totally agree. Things like anatomy that makes transfers more difficult. Again, patients who perhaps have not had a full genetic workup and aren't doing PGT. In some of these other studies, perhaps some of these patients end up having underlying structural rearrangements. So all things that are standard of care we need to make sure that we are offering those things to our patients when they're failing repetitively.
Well, thank you. Another question for Elena is the use of a very natural cycle. What is the threshold of progesterone to, I guess, level to begin scheduling the transfer of blastocysts?
I would say 1. We have analyzed the results, and if you have 1 nanograms per ml and you trigger that day, you are getting late. So nowadays we know that this means that you don't need to cancel the cycle. You just need to advance the moment of the transfer. If you have 1 nanogram per ml, you start progesterone that night and you can schedule the transfer 5 days later. Okay, but because we know that there is no needing to give the ACE. So if you have 1 nanograms per ml, you cannot give the ACE that day and schedule the transfer 1 week later. You just have to program the embryo transfer 2 days before.
Thank you. Well, we're at the hour. Marcos, would you like to conclude?
Well, this has been a great session. Thank you very much. Unfortunately, there are still some questions and people are eager to have some questions answered, but we don't have time. Unfortunately, I'd like to thank both speakers for those fantastic presentations. They have been very enlightening. And just to close the session, I would like people to go to our website and see the different educational proposals we have. The next slide, please. To remind everybody of our World Congress in Tokyo this next April 26 to 29. We'll have a fantastic program there and we would be delighted to have you. So thank you, Kate, thank you, Elena, and thank you, Linda, for a wonderful session. And just to remind everybody, this will be available to you in an archive on our website, so you can see the presentations again and again. So thank you very much to both, and thank you, Linda. Bye-bye.
Thank you so much.
Yeah. Thank you.
Thank you, everyone.
Mm-hmm.